I'll start out. Oh, excellent. I will start off with the roll call. So, Crystal, are you here?
Yep. Good afternoon.
Hello. And Sharon?
Sorry, yes, I'm here.
Oh, Sharon Brown, but
Yes, I'm here
yes,
as well.
I was like, oh yes, there's two Sharons. I forget about that. I was
Sharon
like,
D is here.
The Sharons are here. Excellent. Tony? Maybe not yet. Michelle?
Yes, good afternoon.
Nancy?
Here.
David?
Yes, I'm here.
DC?
DC is joining later, or he might not be able to make it today. He actually sent an email. So
Okay. Chandra?
I'm here.
Meg?
I'm here.
Cheryl? Not yet. Lon?
Lan, I'm here.
Hello. Kevin?
Hi, good afternoon.
Eileen? Katina?
I'm here.
Mandy?
I'm here.
Jonathan?
I am here.
Sarah? Linda?
Here.
Sean?
Present.
Stacy? Ginny? I think I saw her.
Hello.
And Maddie.
I'm here.
Excellent. Well, welcome everyone. I think that's most folks here, and a couple might join later, but I am excited to have you all here. We have a great agenda planned. I'm gonna briefly talk about our charter, and then I'm super delighted to have Larry McNeely, who's the policy director of the Primary Care Collaborative, talk to us about what's been going on in other states and what that looks like. And after he talks to us, then we'll have time for questions. And I'm not sure if Lisa is joining too, bank, but we'll have a discussion then about refining our definition of primary care, and I think let's get started. So the first order of business is approving the meeting minutes. Jean Marie?
yes, thanks, Judy. May I have a motion to approve the September minutes, please?
Motion to approve.
All right. Any second?
Second.
Okay, thank you, Meg. I think that was Meg. All right,
Yes.
wonderful. Vote to approve. All in favor, say aye.
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 Any nay? Nope. Minutes are approved. Thank you very much. And Judy will go to the charter review.
Excellent. And I think Stacy is on, but her microphone is not working because I could not hear her. So yes, welcome, Stacy. So as a reminder, this is our charter. So the problem statement is that our primary care expenditures in Washington state are low, particularly as compared to other states as a proportion of total healthcare spending. And so we are joined together at the behest of the legislature to recommend a definition of primary care and primary care expenditures measurement methodology to the Cost Transparency Board, so that we can start working towards a 12% of primary care expenditure to total healthcare expenditures. And so we have these things in bullet points that are our job to adopt some recommendations. And today I am hoping to check off number one, this come on the statewide definition of primary care. the conversation today will, I think, help with that and also help start to prep the conversation for next time about measurement methodologies for particular claims-based methods and how to overcome. And then we'll get into, in a few meetings from now, sort of barriers to access, how to report, and methods to get to our 12%. So we are having monthly meetings, and I appreciate all of your time. So with that, I am gonna pass it over to Larry, and I don't know if Lisa is gonna help out too. So Larry McNeely is, I said earlier, is the policy director for the Primary Care Collaborative. Lisa Dilsky-Watkins is from Millbank, and she works a ton with Larry and also a ton with states on primary care spend. I would say these two are the national experts that I know of. And so they are here to answer your questions and help in the conversation after the presentation. So Larry, take it away.
Absolutely.
And I'm sorry,
Well,
I'm just going to interrupt for a second.
yes,
So,
please.
Judy, I am here. So
Yes.
I'm delighted to be here and so nice to see everyone.
Excellent. Thank you, Lisa.
I am delighted to say a few things in front of Lisa Dolsky-Watkins, and I think I'd be excited to have a fraction of, I think, what she's been able to learn and help do in the world of state-based primary care reform and investment. So as I say, Larry McNeely, I am with the Primary Care Collaborative. Many of you might have known it's before we were renamed as originally the Patient-Centered Primary Care Collaborative. Next slide. Oh, yes. And so what I'll want to do, sorry, go back one. What I want to do today is give a bit of introduction to our organization. Hopefully we can be a resource as all of you on the advisory committee and the staff of Washington Healthcare Authority are wrestling with these issues and moving forward with the work of the bill. Congratulations on taking a big step towards investing in primary care. I will also give a bit of a status report on the landscape of primary care investment legislation around the country. Before we dive a little bit deeply, and again, I'll be standing on the shoulders of giants here from California, not just Lisa and the folks at Millbank, but also the advocates and leaders at California and Virginia who have been kind enough to share information about what's going on in their states at some of our recent quarterly primary care investment work group calls, which I'll tell you more about later. So I'll have some information to share there. And then we'll try to get granular about some of the choices ahead of you here in Washington about how to measure primary care investment. And the way I'll do that is just by sharing two states and our own reports and how we worked through defining what primary care was for the purposes of those reports. Next slide. So on to the introduction. PCC, we are a nonprofit, nonpartisan, multi-stakeholder organization. 67 members as of today, and we're growing this year. We had a new one pop in. We are broadly stakeholders, many of them national, a few state or regional. We are very diverse, but I'll say the thing that unites them is a commitment to advance comprehensive primary care to improve health and healthcare for patients and their families. And the way we do that is we convene folks. We convene experts to identify potential paths forward. And we convene leaders from around the state in a quarterly primary care investment work group. call. We also convene stakeholders to identify areas for advocacy on which we can agree to advance payment models that support primary care and other policies that support primary care. Next slide. I'll say that I think I just covered this. We definitely convene and raise visibility for primary care, its value to the broader health system. We do disseminate evidence, exemplar models, have an entire work stream lifting up the 24 seminal articles in primary care over the past several years with lunch and learns, et cetera. But a lot of what we do is advocating and supporting those who are advocating for public and private policy change. Next slide. As I say, very diverse, everyone from consumer organizations like the AARP, Families USA, and National Partnership for Women and Families, to health plan and health plan organizations, Blue Cross Blue Shield Association, to major professional societies, physician societies, the family physicians, the College of Physicians, pediatricians, osteopathic family physicians, the physician associates, as well as the American Association of Nurse Practitioners. The list goes on and on, as well as some purchase organizations. So, on to the second part I promised in my presentation. How it started. Obviously, primary care spending has been critical to the broader health system much long before 2018, but so we're starting to see early trends of really disinvestment in primary care kind of across the country, and that's been going on for a while. But at PCC, we turned our focus to, hey, what's going on in the states? Are there a couple of states that might be really taking the bit in the teeth and doing what they could to invest in primary care and change outcomes for communities? And we had two great examples in Rhode Island, that's the little red on the left, and Oregon, your neighbor to the south, who'd decided to measure and increase investment over time in primary care spend. Both of them had rate review processes that they'd leveraged to get system-wide investments, both in the commercial space as well as in their public programs. Next slide. So that's how it started. Next slide. Here's how, oh, one more, sorry, go back. Here's how it's going. We are awaiting a gubernatorial signature in the state of New York, but this is what it looks like in terms of states that have either committed or by passing a law or regulation to measure primary care spend. And if you go to the next slide, I can give a bit more detail on that. We're actually, I think, because of our counting, as of June, up to 19 states, with more possible committed some level of public action to measure primary care spend. I'm actually not counting Virginia, only because they pulled together resources to do some things ahead of their public commitment. They probably should be included, which brings it up to 19 or 20. In 2022 alone, legislation was enacted or passed to measure system-wide primary care spend, or Medicaid primary spend, in Connecticut, California, Maryland, Nebraska, New York, Oklahoma, Utah, and Washington. 6 states have done, or 5 other states have done what you've done, which is set an explicit target in statute or regulation, and are finding ways to pursue that in terms of increased primary care spend. So an exciting level of interest in this. Folks are realizing what we've known since Alma Ata Declaration and Barbara Starfield, that primary care is the foundation of the health system and healthcare system, and it's a interface point with a lot of the community. Next slide. So I want to spend some time, and again, I'll give credit where it should go to some folks from the Blue Shield of California health plan, one of the health plans, and folks from Purchaser Business Group on Health, who came and presented at our last one of our August workshops about the progress they've made in California. And it would have been last year, a couple of years ago, Purchaser Business Group on Health and the California Quality Collaborative, which is a project, it's a purchaser organization there, defined a real shared standard that purchasers had for the kind of primary care they were looking for. And they engaged multi-stakeholder process and came up with a standard of attributes and measures that they wanted to go after in the state of California. And it enabled folks to recognize and identify those things that actually are advanced primary care, and to begin to pay for it differently and facilitate that multi-payer engagement, multi-purchaser engagement that I know folks have been pursuing here in Washington as well. Provided clear guidance on how providers should expect to be delivering APC, so they know, who the folks who are paying them, what they're looking for, and identified some technical assistance that practices would need to do that. So next slide. And I understand that these mirror a lot of the work that's gone before here in the state of Washington, but these are California's attributes of advanced primary care: access to care, continuity, care coordination, population-based, comprehensive, patient-centered, team-based, really similar to some of the original definitions that Barbara Starfield and colleagues have put forward. And a real focus on the patient. There's a real patient-centered approach. Next slide. And I want to share that once we saw this incredible leadership coming together in California with purchasers, engaging their stakeholders in that region, at the Primary Care Collaborative, we worked with PBGH, they're one of our members, another organization, the National Alliance of Healthcare Purchaser Coalitions, that's a regional business groups on health, as well as some of our consumer organizations, AARP, the National Partnership, and had this conversation about how some of the attributes that have been identified, enhanced access, time with patients, realigned payment methods, aligned with shared principles for primary care that over 350 folks had signed on to, that are the real basis for everything we do at PCC, and signed on by a number of clinician organizations and a whole full range of stakeholders. And we did kind of a crosswalk about really seeing the alignment here, and everybody listed on the top and their logos who said, yeah, put our logo on this. It has both the attributes and their shared principles. We know we're headed towards the same thing. Delivery system, purchasers and patients really want to be moving in the same direction here. Next slide. So what's happened recently? First of all, this year, there's been an announcement of a signed MOU with 6 organizations, health plans and provider groups that signed on to an MOU, committed to a shared set of goals very much aligned with those attributes to strengthen advanced primary care over the next 4 years. Big names: Aetna, yes, Aledade, a ACO organization, Blue Shield of California, HealthNet, Oscar, United Healthcare, and the California Quality Collaborative and the Integrated Healthcare Association they have down there had worked together to bring that about. Next slide. And to give you a sense, this slide details, obviously, I think Kaiser's a real leader. I don't have information on whether they've signed on to that or not. but I can check on that. Primary care is at the foundation of what Kaiser does, for certain. So, the principles here that they were going for was transparency, so committing across those payers to reporting a primary care investment, that there'd be a shift not only in that there'd be investment, so increased resources to primary care, that California was going to shift. Those payers agreed that they would shift not just investment, but the model, the form of payment, to a hybrid model aligned with what the national academies have talked about. That's part fee for service. There's a place for that, but also part PMPM, population-based form of payment. And critically, make sure patients had that continuous relationship with the primary care provider and team. PCC, we like to say primary care practice and team practice transformation and real support and dialogue to actually support integration of all the things that primary care is being asked to do. It really feels like the clinicians more and more and more. There has to be support and infrastructure. Next slide. How am I doing on time? Okay. But here also in California, like Washington, I think they followed you guys a little bit, but they went ahead and passed overall healthcare goal setting, spending target legislation and transparency. But within that legislation, within that bill, it passed with their budget this year, they decided to set cost targets by sector and to grow APM, or alternative payment model, that within primary care, there'd be a measurement of the amount of investment in primary care spend, and they'd look to set spending benchmarks. They have a process to do that. They establish an Office of Healthcare Affordability to work through these processes in the state government, and a whole range of supports to help do this and to monitor quality. The last thing anyone wants in this journey is to see, less quality outcomes and less impact on patient population health here. Next slide. Turning to what's happening in the state of Virginia. Very different state than the state of California, but they, at a multi-stakeholder level, similar to what I think has carried the ball forward here in Washington to date, launched a task force on primary care. Beth Bortz out of their Virginia Center for Health Innovation was a real leader in that, presented to PCC's work group about it. In terms of Washington, or in California, if I'm not mistaken, they do have, I don't know who's penalized, but they do have some rate review processes in their insurance market, if memory serves correctly. And I'd have to go back and take a look at the exact mechanism. Again, like you, they're building in their structures of accountability and enforcement for meeting those targets. In Virginia, as I say, there's been a real call to action to address the urgent needs of primary care, broad across stakeholder interest in this, and quite a bit of emphasis on, the promise of primary care, quality care, says lower cost and certainly greater equity across populations. At PCC, we talk, even though we know it's something purchasers want to bring about, you talk about lower cost in terms of primary care, you get folks thinking, well, maybe we can squeeze the level of investment in primary care. It's kind of a backwards way of thinking about it. The reality is we have to invest in primary care to have that foundation that allows more sustainable trajectory for health spending and better value over time. Next slide. So they had a set of definitions of success. And what I wanted to draw attention to you here was that their definitions of success involved a vision of primary care services that, again, similar to Sarfield, similar to what you're working with here, accessible, integrated, equitable, convenient, and affordable. They wanted to make sure, as in California, and I should specify that, well, we didn't, slides here didn't go into it. In California, they actually, those 6 payer organizations that signed an MOU, and the provider organization Aledade, about primary care spend and moving to a new model. They also agreed to a concrete set of metrics, a core set of primary care metrics. So going beyond payment levels. So they're working towards that, those shared quality and performance metrics as well. So here in Virginia, they wanted to have predictable payment for practices, but it be tied to meaningful performance measurement, and that they wanted to support innovations that had adopted during the pandemic. How am I on time here, Jean Marie? Well, let's start kicking forward here.
You're doing all right. You're doing okay.
Okay, next. Their task force, just to underline a point, is a third primary care clinician, a third health plan representatives, and a third employers and state government officials. At PCC, we've interviewed a number of states. Wasn't a report that I put together, but Ann Kemsky from our team interviewed a lot of states, and their effort to build support, and found that multi-stakeholder engagement from the get-go was critical. A bit more about that later. Next slide. And just to say, their task force, their key accomplishment is that they have put together, and I've yet to see the publicly released copy, but they have, as of this year, developed a measurement approach to total cost of care and primary care spend methodology, and they've put together for their internal use baseline reports. I don't remember seeing anything about going to that question, accepting all willing providers across payers anyway. It would seem like that would raise a holler from some of our payer friends who do like to curate networks. So I doubt that I'd see that, but I cannot recall seeing anything to that effect.
Sorry, I don't want to take
Yeah,
up
go
your
ahead.
time, but I was asking if, in order to participate, that a practice needs to accept multiple types of insurance. For instance, they can't get into a contract just with Blue Cross of Virginia or whatever as a single, like they have to take every payer.
Yeah, all of their patients are with Blue Cross of Virginia.
Right. Is that allowed there?
I don't have I'd have to take a look at the MOU. I will actually share a link to the MOU post presentation.
That'd be helpful to know. Thank you. Sorry.
Yeah, very good. At least point you in the right direction there. And if need be, email me. I'll leave my email and we can dig some of that out. The folks in Virginia also wanted to talk to primary care clinicians. Let me encourage you guys to, and I believe we have several of them on the call, that being critical. They actually did a practice survey that Virginia Commonwealth University conducted. And they, for internal decision-making purposes, put together a primer on other states' Medicaid primary care payment reforms. There was a real focus in that state on starting on what they could do immediately in terms of policy in the Medicaid space, where oftentimes you have the greatest, kind of the lowest levels of primary care payment. And took a look at the workforce. Where was the workforce, and where's the ownership? Who's paying who here? Next slide. They wanted to look at the ideal state for primary care, and they actually found consensus around their around performance measurement categories. I'll see if I can't get some of these slides, see if the original slide deck is something that folks would be comfortable sharing. And again, these are Beth Bort's slides from our work group that I'm sharing with you. They've developed some information on primary care infrastructure supports. And I'd be happy to put the folks here at Washington Healthcare Authority in touch with the Virginia Task Force, because the more information sharing, the better, as well as some of the leading lights in California. Next slide. Now, I think, again, to the idea that there's momentum growing here, in the Virginia task in Virginia, they haven't won their statewide legislation mandating this, but they did win continuation funding to continue their work on reporting for the task force to build on their baseline data and see how it's changing over the next year. They identified a priority on data sharing for practices around immunization and went over and got resources. And they were able to win increased payment for Medicaid primary care services, an $81 million investment. And as somebody who cares deeply about making sure all payers are doing what they can to support primary care, that we don't have a two-tiered system, exciting to see that. Next slide. And they've got work ahead of them. So they're expanding their primary care spend and total cost of care reports to look at trends, assessment of COVID-19. They are looking to build a primary care scorecard for the state. There's been a patient-centered primary care measure and a What Matters Index that folks at Rebecca Etz and folks at Virginia Commonwealth University have put together. They're looking to pursue, and they are encouraging and documenting health plans to adopt the core quality measures collaborative metrics that are out there. That's of course a national body that's sought to identify core quality measures as a template for individual payers. I'll see if we can get the I'll try to download the chat and provide some information to Jean Marie and see if there's some of these resources we can share. So thanks for that question. Now, on to what folks came to see, in addition to what other states are doing to capture imagination. The work ahead of you initially is going to be defining primary care spend, as I understand it. Don't let me try to define your work for you. But as at PCC, how we've thought about and how other states have thought about it, obviously there's two components, potentially measurable primary care spend, your claims-based and your non-claims-based, various forms of non-claims care management or capitated fees that aren't based on some kind of underlying claim resources. And within claims-based spend, there's kind of two levels of analysis, and states have started from different levels into making their definition, crafting their definition, and folks like us who've done reports on commercial data have done the same thing. The first is what could be referred to as a taxonomy, literally which types of clinicians provide primary care services. Is it family physicians? Is it internal medicine? Is it pediatricians? Is it what happens to nurse practitioner provided primary care services? Physician associate? How about gerontologists? Naturopaths? And I know some of these are dictated in statute. So that's the kind of thing when I refer to taxonomy. Second are the actual services provided, the code by code analysis of what you're calling primary care or not. And I'll walk you through three examples of how folks have looked at this. One, first, take as our example, an analysis that was included, put together by our CEO, Ann Greiner, Primary Care Collaborative, and Ann Kimsky, aforementioned advisor to the PCC and member of our team. Next slide. This took a look at commercially available data on commercially insured folks across, I believe it was 50 states, through 2017 through 2019, so pre-COVID. And using a couple different definitions of primary care, a narrow definition and then a broad definition, we actually saw overall nationwide spending, and it's broken down in this report state by state, of 4.88% in the narrow definition, and it was falling, as you can see. Broad was 7.8 in 2017, again falling by about a little over a tenth of a percentage point with 2019. If anyone else has a sordid history in public health in their aspects, that's not necessarily the direction of prevalence of some of our core health concerns. But primary care spend is falling, and that's consistent with what some of the literature has found over time. All payer finding a decline, 2002 to 2016, JAMA, and again, these resources will be available, the sites at the end of the presentation. Similar trends in commercially insured research in the literature. Next slide. So for our broader findings, how did we define primary care? Well, we held constant in our definitions of what's narrow and what's broad a certain set of services. Broadly, services delivered in an office, an outpatient setting, so we excluded inpatient. We looked at evaluation management visits, a whole set of different preventive visits, and care transition, your care coordination codes, screening and counseling. And these were claims-based. This was a claims-based analysis. So excluding all of those critical non-claims-based resources. So our narrow definition included those, again, holding those services constant: family medicine, internal medicine, pediatric medicine, and general practitioners. Those are the only ones we looked at in defining that 4.88 to 4.79 narrow definition. Our broad definition took a look at those services performed by nurse practitioners, physician assistants at that time, now physician associates, geriatrics, adolescent medicine, gynecology. So that's how we, in that particular study, put those definitions together. And some of that was dictated by data source. Next slide. So the second example, the New England States All-Payer Report on Primary Care Payments, I'm just using a couple of slides by the late and great Richard Slusky, who's been a real leader, had been a real leader, working with NESCO, the New England States Consortium for Systems Organizations. They put together a number of states doing all-payer claims databases there, decided to have a single report analyzing primary care spend using common definitions across all 6 states. Most of them have their own separate reporting processes, but this had, they wanted to identify a common methodology. So next slide. And to say, took a look at some details about their report. They found 5.5% for a narrow definition, 8.2% for a broader definition. They did include OBGYN providers and services, but they were included separately, reported separately. They weren't included in the narrow and broad definitions. They didn't include naturopaths and behavioral health providers. They collected some information from payers, but it was really scattered on non-claims payment. So that was kind of a weakness in that report. Next slide. And here's some of their findings. They identify some spending information across definitions 1 and definition 2 by payer type. Next slides. And they did have Medicare fee for service available in their states because they had all payer claims databases that I understand that relied on some of the QE information. So here's a slide on their definitions. Their their narrow definition was selected claim. What they did was kind of the obverse of what we were doing. They held the clinician type constant. It was all general practitioners, family medicine, pediatrics, internal medicine, nurse practitioner, PAs, held those constant, and then changed and then moved on to a broader definition that didn't restrict on service code. They went through and identified specific services and used that to construct their narrow, then used the same taxonomy, but expanded the set of codes or the set of spending. So it's essentially all claims payments by those clinician types. And then it reported separately for OBGYN providers on selected OBGYN services. And they took their defined PCPs and identified the level of spend that were OBGYN services. So that was an entirely separate process. Next slide. So your neighbors to the south went and took a look at their 2020 primary care spend reported in 2022, I believe here. They have defined list of what taxonomy they're working with. Physicians of various types, includes OB/GYN, includes physician assistants, naturopaths, and specific nurses. They also included in Oregon certain services delivered by primary care clinics, FQHCs, and rural health clinics. A critical piece of the primary care infrastructure, especially for the safety net, and it's often on different coding codes that they use. Next slide. And here were broadly the services types of services that they included in their definition of primary care. Their OB services excluded delivery, as well as some of these standard models. Next slide. So I'm going to call out a few additional resources. We do have a primary care collaborative state investment webpage. It's right there. I think in the slides, the link should be live. If not, I'll include it here. There you can navigate to a couple of resources, but I've also included links here. PCC's own consensus recommendations on primary care investment by states we put together in 2018 as we were starting this work. Lessons from multi-stakeholder advisory groups, which is the reference I mentioned very at the beginning here that had how states put together the multi-stakeholder support they needed. Finally, a couple of other resources, measuring non-claims-based primary care spend. This is a Milbank Memorial report that I know we're not dealing with heavily today, but it's a methodology that I think Bailitt put together for Milbank on how to do non-claims based spend. There might be a Bailitt on this call, I'm not sure. Another resource when you get past the taxonomy and start worrying about the services that are included, California Healthcare Foundation, roll up to their MOU and their state legislation, did a lot of work. Friedman Healthcare put together a lessons from other states document. Along with that, you had to dig through their website to find it at California Healthcare Foundation. They had a primary care CPT, common procedure terminology, crosswalk across 10 different reports on primary care spend, which codes were included on claims for which report. So that is a incredible resource if you get into those weeds. Next slide. Here are some of the sources I referred to, and that should be useful. Next slide. This is my contact information. I don't have a slide for it, but I do want to suggest that in addition to questions here, let me try to be a resource. Let me connect you to other resources, because PCC has been with the help of our partners at Millbank, and Lisa Watkins has been an incredible resource, putting together, has really become a bit of an information sharing resource and a backbone organization for folks from a whole range of states doing this work. We meet on a quarterly basis. Our next call is coming up, oh my goodness, on the 2nd of November, which is next Wednesday. Individuals here would be welcome to join either that meeting or the one moving forward. If you're interested in joining those calls moving forward, drop me a line. It's a great way to keep up to date with how this movement's moving along. Gosh, I've talked too long. Have I filibustered
great.
you, Lisa?
Yes,
Oh my God.
Thank you, Larry. And now we have some time for questions for either Larry or Lisa based on their experience in other states. So yes, if you want to know about what someone else is doing or more about these resources, now is the time to dig in.
Well, I guess I can start digging in. I was interested in the slide showing that primary care spending had gone down between 2017, 2019. But I'm interested to hear on thoughts as primary care as a percentage of total spend, where, is the right interpretation that spending has gone down, or just that it's a smaller share? And is there
Excuse me, smaller share.
Okay.
Yeah.
But is there a risk with measuring primary care as a percent of total spend, that even if you're, gaining ground and increasing total primary care spending, that it starts to look worse in a metric like this?
I think it's vulnerable, but I think put it together with to that potential argument against it. The reason why, I think one reason why we went there is when we took a look at the international funds, or sorry, international pattern. Some of this data is, it's not ideal, the comparisons, but a lot of other nations with similar well, maybe not similar economies, industrialized nations, OECD nations, are investing more in primary care. So, sorry, Lisa, I saw you ready to.
No, I think that's an excellent question, but it is the standard of the way we look at it. And so Chandra, I think the risk is there, but I don't, it's just sort of the convention.
Okay, yeah.
I will say that
I mean, we're gonna, just so you know, to preview a little bit, PCC has its own evidence report every year. This year it's on patient matching and usual source of care. You'll hear more from Ann Greiner, one of the authors, if you're able to join our, probably the 16th, we'll have a release, but it's going to show that there's a substantial fraction it's not a majority of folks on MEP surveys saying they aren't reporting a usual source of care. You know, that represents a gap that's potentially worth closing if we're serious about population outcomes.
We have several questions in the chat. Sharon, were you next? I was trying to keep track.
Perhaps this is really quick because it just follows on the last question about, so if it's a percent of total spend and it's going down, so which areas went up? Is there any that particularly stands out? I have a guess, but I don't know. So what did they find?
Our analysis was with regard to in this particular report was with regard to primary care spend as a percentage of total healthcare expenditures, not the drivers of spend. And it was again, a commercially insured population.
You know, if people are saying they don't have a usual, you know, source of care or whatever, you know, it leads you to think maybe it's specialists, could be hospital outpatients. And our tasks may not be, I know what our tasks are, which I come up with a definition and a couple other things, but you know, given that there's X number of dollars and we need to come up with 12% of X, that means somebody's going to lose like 5% of X, right? And so we kind of need to know where that's going. Thank you for answering.
Sure, the larger cost board has been looking at that and has been looking at hospital spend and looking at the other areas. So our focus is really just on the primary care.
And sorry, I know a lot of folks have a bunch of questions, but we are scheduled to do public comment, and I do want to respect that as this is a public meeting. So Judy, can you lead that real quick? And then if folks still
come back to questions.
Yeah, we can come back.
I do feel like this is really important to have this conversation. So
yes, absolutely.
Yes. So now is the time for public comment. If there's anyone that wants to provide public comment, please state your name and affiliation before speaking, and you can also give them public comment to us in writing.
Hello, can you guys hear me okay?
Yes.
Yes, today I'm providing public comment. I'm with Pacific Source Health Plans. I may take over for Meg, who is currently a member of this. I worked on this topic here in Oregon for our health plan. I would just comment that the questions that are being asked are very prudent and important. The moving denominator is definitely an issue, and if you're shooting for 12% and for example, pharmacy is becoming a dramatically increasing percent, then it does pose a challenge. So I would encourage this group to continue to look at the denominator and recognizing that as that continues to increase in whether it's pharmacy or specialty care, that will be an ongoing challenge going forward. And I think, you know, really getting to that definition, which I believe this group is working on, of what is primary care, was a challenge in the state of Oregon. And as you can see from the presentation, different states have taken different approaches, and you know, Oregon includes some behavioral health in that. And those would be my comments for today.
Thank you. Anyone else? Great. Let's go back to questions. I don't know, Jean Marie, do you know who was next in line?
I want to say, Sharon, did you start asking your question? I'm sorry. I think you were next in line.
Unless it's Sharon B, I had my question answered. Thank you.
Okay, then maybe, well, Michelle has hers up, so she's and then I know Nancy, sorry, I saw you too, so we'll get to you both. But Michelle, go ahead for the time being.
Hi, thank you. My question was along the lines of including pharmacy in the denominator as well, because I did notice some of the studies excluded pharmacy, including Oregon and I believe the New England states. So are we allowed to comment on, is this group working on the denominator as well, or are we really only working on numerator? Because I believe pharmacy should be excluded just because of the volatility and the costs, especially in the last 10 years. So that's what I wanted to talk about, was more the pharmacy aspect.
Yeah, Larry or Lisa, can you comment about how other states have approached the pharmacy part? I do think we need to, that sort of everything else goes into the denominator. But comments on that from you two?
Well-
Obviously, well, you've seen that it has been not included, but I think it's a really reasonable discussion, and it's something that we certainly be glad to do a little digging in the states that we understand more about what they've been doing over the last couple of years, and get you sort of the range of that and with more specificity. I don't have it off the top of my head, but we can certainly deliver that information to you.
And I can say that in direct answer to the question about our 2020 evidence report, that the Fair Health data set that we used to do the analysis did not include RX data. However, there appears to be some form of imputed spend that was included there. So I'll have to get a bit more data on that, but that's out of our appendices. So thank you.
And then Nancy, I think you were next. You've been patiently waiting.
Thanks very much. So my question is related to claims-based versus other ways to measure spending. And when I say that, I mean, so you alluded at one point, or you said that there was some transition, or there was some proportion that was per member per month spend. And as we transition, or as there is potential transition, suppose you have a advanced primary care practice that takes care of a panel of, X number of people, and a lot of those people are per member per month rather than fee for service. How are we going to capture that if we're comparing this year's rates to next year's rates and into the future? So I don't know if there's like a concrete answer to that question, but hopefully we'll transition more to per member per month for primary care practices. So thanks.
I turn to Lisa on that one.
Yeah, and there is for sure Millbank, and I'll let Lisa talk, but we are going to have to decide the non-claims based primary care spend as well. That'll be part of the recommendations that this group makes. And yes, Lisa has
Right. Well, and I was not involved in the authorship of that report that Larry referred to, that would have been done several years ago now, from Michael Baylett and Rachel Block, who's my colleague at Millbank. I think it might be helpful to certainly review that, and I think Larry, you already put a link in your slides. Is that right, to that report?
That's right. Yes, and I can also say that Oregon, I suppose methodology would very much differ, but Oregon has come up with a substantial, I don't know if that's majority, but it's a substantial amount of their primary care spend through non-claims based. There's also the reality that a lot of those PMPMs are based on kind of non-paid claims, at least when you look at some of the public programs elsewhere. So folks are doing it as we speak.
But there's not a consistent
methodology,
which is what you would like to be able to see, to be able to make your decision about how you're going to do it. And so that doesn't exist in terms of there being a standard, but there are examples, as Larry said, in Oregon and a couple of other states, and the early paper that we got from Michael Baylett, and he may be willing to come and speak to you about that as well, which could be helpful.
Thank you.
Cheryl?
Thanks, Judy. Yeah, Judy won't be surprised. I'm a pediatrician, so to hear my question then. So have you looked at how this may or may not be different if you look at pediatric specific population? Because we already, I suspect our percentage of primary care spend, and I think some of this came out already in our preliminary data here in the state, that it's already higher for us, but I don't think anybody in peds would say we're doing a stellar job necessarily of taking care of our population. So I'm just wondering how you think about that.
So I'll answer just as a pediatrician as well. I mean, this really does beg the question about so many of the programs, at least that came out of the Innovation Center at CMS, were so focused on Medicare and in an older population and chronic diseases. And I think that pediatric population is very different in terms of what the bulk of the services are that we deliver in terms of, anticipatory guidance and health maintenance. And those things are just so much of a focus. That being said, I think there are ways to both measure that and to have it be consistent with the way that primary care is measured overall. And it has to be part of the equation. So I think it's a really important point.
Yeah. Ends up being not in the medical sector. Our kids are medically generally healthy, but they are not healthy in a lot of other ways. But that doesn't hit us on the medical side. So it's happening in the schools and in childcare and in juvenile justice and other places that are outside of our healthcare spend. And I know that I know there's some, not that it doesn't happen in the adult side either, but I just think it's really unique because generally we're talking about a much healthier population in pediatrics.
Right, but there's still huge resource issues. I mean, just in terms of mental health services for kids and things like, that it's a giant chasm of need and not a lot of
right, but that wouldn't be in primary care. I suspect that's not primary care spend. That's what, I'm just interested in how we approach, how we're going to approach that, and even should we be age banding how we look at spend.
That's very
Let
good
me-
question.
It's an interesting idea. And I'm, think you'd be better qualified than I to identify kind of what a good target for this age group versus that age group might be. But I would say, just to the point about behavioral health, depending on how you constructed your definition, what happens if you have a situation where you're implementing, say, out of the AIM Center at UW, collaborative care in a pediatric practice? That's, you may want, not to presume, you may want to make sure those collaborative care claims end up flowing into primary care spend. There are a few states who have looked at measuring both primary care spend and behavioral health, and then you've got to decide kind of what's what and how the differing definitions interact. If you look at the crosswalk on claims, and I can't say whether it's a matter of methodology or whether a matter of intent. Some states include psychotherapy delivered by their chosen clinical types as a primary care service. If it's delivered in a primary care setting, maybe some don't. So, there are choices ahead on those very detailed things, but I think it starts with that definition of the taxonomy.
Yeah, thank you.
And Michelle, I know you have a question, but I also saw a question from John in the chat about telemedicine. Lisa and Larry, did you want to address that?
So I don't know the answer to the question. I think it's very important though. And obviously exceedingly so over the last few years. So I'm sure that will be addressed.
Okay, great. Michelle?
Yeah, just expanding a little bit on the comment regarding looking at cost by age band. What about by line of business? Because, for example, Medicare is going to have much higher specialty costs, much higher hospitalizations. So are they doing it by line of business? You know, these other states, like what's going on in that aspect?
So I can certainly attest to, only because it's the one that I've reviewed most recently, the NESCO report. The NESCO report certainly does, and it would certainly be desirable to take a look, because apples, you know, we really are comparing apples and oranges. If you're talking to you know, if you're in a setting where, as the health authority, you're talking to a payer and saying, you know, where are you at relative to the target? You know, well, it's going to look different for an MA only plan versus
Right. Well, and even in the commercial market, there's so many different, the rates can be completely different, you know, across provider groups.
Right.
Whereas Medicare and Medicaid are a little bit more standardized,
Right.
at least in terms of fee schedule. So that, like, do we use more of a standard cost type of look to try and even some of that out as well? So just another thing to think about.
I wonder if it'd be helpful to talk to the people from OnPoint who did the data collection analysis for the NESCO report. Just something to think about too, because you may be able to really dig into more of the weeds with them.
Yeah, thanks for pointing that out, Lisa. I'll put that on my radar for some more data collection and analysis on our part. Crystal,
I
you want
apologize.
to-
I have a hard stop at
Oh,
5. So that's
that's
okay.
okay.
Thank you. First of all, great. This is so exciting. I know it's really hard having to roll up your sleeves and look at all the details. Larry, great job. Thank you for
Yeah.
your presentation.
Hey, before you go, let me just shout out the partnership with Millbank. It's going to produce something very soon. We have in our state investment webpage, we're going to have a web tool that lets folks like yourselves take a look at, and then, you know, regularly updated look at what all the various states are doing, where their legislation stands, where their level of standards are, and eventually we'll be having well, really by the end of this year, we should have ability to point to how they've constructed at least the legal architecture for their measurement, as well as their actual reports. Some of that is available now on that state investment webpage at PCC. So,
Right. This is
and I couldn't be doing that web tool without support from Millbank.
Right. Well, we're delighted to be able to support that. So it's an interactive web-based tool with not exactly real-time updates, but pretty darn close. And so the opportunity to be able to again, have a single source for information, at least as best as we can provide it. Thanks, everybody. Really nice to see all of you.
Thank you, Lisa.
And keep up the great work.
Thank you so much.
Larry, can you stay on for a bit
Oh,
more?
yeah,
I think
I'm
there's
here.
there's maybe another question from Crystal.
Yes, there is. And actually, that was a really good segue. As we're looking at this, it would sure like to be in the, you know, as we're thinking about defining something new, it's been defined by so many others. We want to be consistent so that we can have some comparability to some degree and don't want to recreate the wheel. That's one of kind of our objectives, I think. So it sounds like that website will give us a little bit more of that. The question I have for you is, of all these studies, if there's one that kind of encapsulates a larger group or a larger data set, I think that would be meaningful. I like the New England that captures, you know, a lot of individuals in that study. But is your website then, would we be waiting for that to see what definitions there are that cover like the majority of different individuals, I guess?
So what we do have already on the website is several examples of other states' published reports. It's up on the top right, and I'm about to, if you want to, Jean Marie, if you want to make me co-host, I'll share just that part of my screen. But
Oh, well, testing my Zoom abilities here. Let's see.
Oh, you know what? I think you'd have to pull down your presentation.
Oh, just stop sharing my screen. Sure.
Yeah.
Basic thing there. There you go.
Okay. And forgive me, I'm about to zoom all you guys out here, but we are reworking this. But if you take a look at this web URL, here are state reports on primary care spend. I think we have the original Rhode Island one. And I'll say that in states like Rhode Island, who've been working this aggressively for a number of years, they've been able to see real progress and overall investment across payers in that state. Okay, so that'll show you, and also down towards the bottom, you can take a look at the same information. This will probably be where our new web tool lands. So enough out of me.
No, that's great. Thank you, Larry, for sharing that. I know that I've been poking around in there and I'd seen the list of reports.
But you get lost in the PCC website.
There's a lot there. Yeah, yeah, which is great. Any other questions from folks?
David?
Larry? Yep, David.
Yeah, thank you, Jean Marie and Judy. As a carrier, we had to respond to the HCCTB data request, and that data request outlined a definition for primary care, and it was based on taxonomy and a list of procedure codes. It sounds similar to the Oregon definition. Do you know anything about how that definition came to be, and if that is a temporary definition for the initial data reporting, but the HCA and HCCTB hasn't settled on that as a definition?
Yes, I can take that question. So HCA has been measuring primary care spend, both claims-based and non-claims-based spend. We haven't made the non-claims-based spend public, so it turns out it's pretty messy. I'm not 100% sure of the accuracy, but we've been measuring both of those, and we have used the OFM template that was made in 2018, I think, Mandy, when you last convened those folks, and it's good. It's in line with other states, but this is really a sort of a broader stakeholder approach, I think, and legislatively directed to figure out, should we keep using that definition, which is one option, or are there things to tweak? I think one of the things, and I don't know, Larry, you might want to talk about this, probably the most important part about measuring primary care spend is that you don't change it a lot. And so, because otherwise you don't know what's happening really. And so, once we make, this is our first look again at whether that OFM spend is what we want, or if we want to do something else. And they didn't do non-claims based spend. So that's something that HCA has created on its own. Yeah, I don't know, Larry, a good question for you is, how often do states revisit their definition, especially Rhode Island and Oregon?
I don't know the answer to that question. I apologize. I can certainly dig into it. I mean, I think if you're a state, it would just, it's hard to execute towards a goal if you constantly change the goalposts.
Excellent. Any other questions for Larry?
Folks, I'm
Parting
honored
thoughts?
to have been here. Thank you for inviting me, Judy, and Jean Marie for working with me. And I'm in awe of what everybody in the state of Washington's been doing generally on healthcare, and excited to share some of what's going on around the country.
Thank you so much, Larry. We really appreciate your time. Great presentation. And we'll be in touch for sure. I'll be in touch with you. So
Very good.
Yes.
Look forward to hearing from folks.
thank you.
So we don't have a ton of time left together, but maybe I will, I'll quickly go through the slides. We won't have time to talk about it, but hopefully it'll keep your wheels thinking. Our next meeting, we will hopefully make some decisions about the definition, and also we are going to have Josh Lau from the University of Washington has done some contracted work for us at HCA about refining the OFM definition and diving into, they've mostly been looking at our Medicaid claims and looking at some different pieces of that. And so I think that'll be a really nice, like, next step into this. We're sort of easing you into the steps of different things. And so I will talk about this, and then I think we'll be done for today, but it'll give you some things to think about. So when we look at the claims-based primary care spend, that's where we'll be looking at the narrow and broad pieces that we talked about today. So this first definition is really nothing about narrow or broad definitions, but all about sort of what are our core principles in terms of defining primary care as Washington State. And so this definition will guide how we then decide what gets put in and out of claims-based and non-claims-based measurement discussions. And we won't draft a definition today. In fact, we probably won't draft a definition until next time, but that is where we will be. So next slide, please. So I wanted to remind folks, we do have some of this in statute and in codified language from various things. So the RCW is the legislature's definition of primary care, and this is really just a who is primary care. We can't change this, so this will be at least part of our start of a definition. There is also insurance code that applies to all commercial insurance in our state that says primary care means the routine healthcare services, as you can see here. Again, both of those are very high level. We won't be changing them, but I think help to start get at what gets included and what doesn't. In my mind, I think thinking about once we get to the claims-based and non-claims-based measurement, we'll need to think about who, what kind of providers, where, clinics, hospitals, home, all the settings, and then what. So that's where the services come in. And I didn't know until today about California's list, but that CPT code list might be helpful for us as well to look at. So next slide. We have also, as I mentioned at the last meeting, had a fair bit of groundwork done on this that I think we want to build on and not necessarily change. So the first is the OFM definition that was stakeholdered and made in, I think, 2018. And it was based on the 1996 National Academy of Medicine definition. And that is here, and it did define narrow and broad in their definition. The BRE got together a group, as many of you know, and they started with the OFM definition and then sort of added some of their own things. So the BRE definition is on here. And you can see there's a fair number of similar words and similar words in what Larry shared as well in terms of how other states are defining primary care. So this is sort of a side-by-side of some of those most important words that I think we can talk about what we want in our final definition. And then the next slide, as I think all of you know, here's the BRIE definition again. But the National Academy of Medicine has made a new definition. They had a new primary care report that came out last year. And this is that definition. So this came after the BRIE. And again, there are a lot of parallels here. And I think good pieces that we probably all will agree on. And so for our next, oh yes, and thank you, Jean Marie. So, oops, back one, please. Yes. So here's those words sort of put together again. There are very similar things. So, you know, the BRIE said comprehensive, the National Academy of Medicine said whole person integrated care. So they're sort of the same thing, but said in different ways. Similarly, continuous versus sustained, maybe that means something different, maybe it doesn't. So, so that is this. And then I want to make a note about appropriate. Oh yes, so Jean Marie just said appropriate really means evidence-based in this context, is how the BRIE was thinking about it and how the discussions evolved. So, so that is a quick run through and hopefully will provide you some fodder for discussion. I think next time we may flip through these slides quickly or maybe just pieces of them to start our discussion on what is our overall definition of primary care. But now the next slide. So we'll compile comments. We won't distribute the final recommendation because there is not one yet, but that'll be saved for next time and good discussion. Thank you all for joining. We'll put the recording and the summary on our website, and our next meeting is Monday, November 21st. So any last parting questions? Then great, thank you all. Enjoy the rain and the fresh air, and we'll talk to you next month, if not before.